Okay, let's unpack this. Today, we're diving deep into something really, really important if you're heading towards surgery, especially if you manage diabetes with non-insulin glucose-lowering medications. We're talking about how you handle these specific drugs before the operation. And look, this isn't just some minor detail, it's genuinely about your safety. It's about preventing complications and, well, making sure things go as smoothly as possible. So, our mission today, to kind of distill some, frankly, complex medical guidelines, break them down into clear, actionable insights for you so you can have better, more informed conversations with your own doctors.
Yeah, and what's fascinating here and really crucial to state up front, while this deep dive gives you a great overview, sort of bird's eye view, it is absolutely critically important that you talk about your specific health situation, your particular meds with your personal care team because, this general info, it's definitely not a substitute for tailored medical advice.
Yeah.
Your team, that's typically your primary care provider, maybe your endocrinologist, your
Yeah.
surgeon, and definitely your anesthesiologist. They're the ones who put it all together for you. They create your plan. They're essential partners here.
That idea of personalized care seems, yeah, absolutely intro. And it brings us right to the core challenge. Why is managing these meds before surgery so, well, tricky? This is where it gets really interesting, I think. When you're getting ready for surgery, your whole routine kind of goes out the window, doesn't it? You might be fasting, your diet's different, activity levels change. All that can have a huge impact on blood sugar. So what are the main things we're trying to dodge here? The big risks.
Well, the biggest worries are really those twin dangers.
Mm.
Hyperglycemia, that's high blood sugar, and hypoglycemia, which is dangerously low blood sugar. Both of these can cause serious problems around surgery time. Things like delayed wound healing, issues with heart rhythm, even neurological problems. So if we connect this to the bigger picture, the main goal is always achieving good glycemic control, keeping blood sugar in a safe zone, basically. While, and this is key, carefully avoiding those extremes. It's a real balancing act. And honestly, this complexity, it's exactly why we see different clinical practice guidelines out there. They come from various medical societies, and they don't all say the exact same thing. There isn't one single playbook that fits everyone. That's vital to understand.
It really does sound like navigating a bit of a maze with all these recommendations. So can you give us a sense of who's actually writing these different guidelines? I imagine it's, the big players in the medical field.
Oh, absolutely. You've got various major organizations involved, like the American Diabetes Association, the ADA, the Canadian Perioperative Anesthesia Clinical Practice Guidelines, CPOC, the Association of Anesthetists of Great Britain and Ireland, that's AAGBI, the Society for Ambulatory Anesthesia, SEMBA, and even specific large institutions like the Cleveland Clinic, for example. They've all developed their own sets of recommendations based on, well, their research and clinical practice.
Okay, so why the differences then? Is it just different opinions or is there more to it? That raises a really important question, doesn't it? Why aren't they all identical? Well, these differences often come down to a few things. Maybe variations in the available data they looked at or how studies were designed. Sometimes it's the specific patient groups they focus on. And, medical research is always evolving. What we know improves over time. So what's best practice today might get refined tomorrow as new evidence comes out. But this variety, it really just highlights again why you need that personalized advice. Your team looks at the guidelines, sure, but also your health history, your meds, the exact surgery you're having, to craft that plan just for you. It's very much tailored.
That really hits home that you, the listener, need to be having these specific talks. So, okay, knowing all that complexity, the big question is, what do you actually do with your medications? Let's dive into some of the most common non-insulin drugs and see how these different guidelines suggest managing them before surgery. We should probably mention the usual holding period and maybe a key potential side effect to watch for around surgery time, that perioperative period. Sounds good. Let's start with metformin. It's probably the most prescribed one for type 2 diabetes, right?
Yeah, seems like it. And just quickly, how does it work again? It helps your body use insulin better and reduces sugar from the liver.
Exactly. You've got it. Metformin basically reduces how much glucose your liver makes. That's hepatic glucose production. And it improves insulin sensitivity, so your body responds better to its own insulin. Now, managing it before surgery, this is where you see those differences clearly. Some guidelines, like ADA and SAMB, suggest just holding it on the day of surgery. Pretty straightforward. But others, like AGBI, say hold it for 48 hours beforehand if you have kidney issues or if you're getting IV contrast, dye, the dye used for certain scans. And then, interestingly, Cleveland Clinic often recommends continuing metformin as usual right up to the day of surgery. That reflects their local practice.
Wow, okay. Day of, 48 hours, or continue. Quite a range.
It is. And the key insight, the reason for those 48-hour holds, it's the rare but serious risk of lactic acidosis. That's a severe buildup of acid in the blood. Very dangerous. So making sure kidney function is good is critical, especially if kidneys might be stressed during or after the surgery.
That really hammers home the need to talk to your specific doctor. Okay, next up. Sulfonylureas, drugs like glyburide, glipizide, glympyride, and also meglitinides like ripaglenide, nataglenide. How do these work, and what's the general approach pre-surgery?
Right, so these drugs work differently. They actually stimulate your pancreas to release more insulin. And for these, there's much more agreement among the guidelines. They are typically held the morning of surgery. The main reason, a high risk of hypoglycemia, the dangerously low blood sugar, which is especially risky when you're fasting before an operation. You don't want someone under anesthesia having a severe low. Now, meglitinides have a really short half-life. They're out of the system in about an hour. Sulfonylureas last a bit longer, maybe 2 to 10 hours half-life. But still, that significant hypoglycemia risk means holding them before the procedure is the standard advice.
Makes sense. Okay, moving on to the SGLT2 inhibitors. These have become really common. Canagliflozin, dapagliflozin, empagliflozin, ertugliflozin. And the advice here seems quite different, holding for days beforehand, not just hours.
That's an excellent point, yes. A critical difference here. With SGLT2 inhibitors, most guidelines, ADA, CPOC, Sambiao, recommend holding them for several days before surgery, usually 3 to 4 days prior. The FDA specifically says 4 days for ertugliflozin. And the reason for this much longer holding period, it's the risk of something called euglycemic diabetic ketoacidosis, or euglycemic DKA.
Euglycemic DKA, that sounds complicated.
It is tricky. TKA is when your body produces high levels of blood acids called ketones because they can't use sugar for energy. It's serious. The euglycemic part means this can happen even when your blood sugar levels look normal, which makes it incredibly hard for the care team to spot quickly. There's also a risk of volume depletion, basically dehydration with these drugs. Both DKA and volume depletion are major concerns during surgery and recovery. They can lead to kidney problems or other severe issues.
Wow, okay, that's really eye-opening, especially the normal blood sugar part. What about the GLP-1 receptor agonists, like liraglutide, semaglutide, dulaglutide, and those newer dual GIP-GLP-1 agonists like tirzeptide? These are super popular now, partly for weight management too. What's the advice here?
Yeah, another interesting class. And here the advice is quite varied again. Some major guidelines, like ADA, CPOC, AAGBI, actually don't have specific recommendations for these yet. But others, like Samba and Cleveland Clinic, do offer guidance. For the ones you take daily, they might suggest holding just on the day of surgery. But for the weekly injections, it's often recommended to hold them maybe 4 to 7 days before surgery.
A full week. Why so long for the weekly ones?
The main concern is their potential to delay gastric emptying, meaning food stays in your stomach longer than usual. And that can lead to nausea, vomiting, especially around the time of anesthesia, which increases the risk of aspiration. That's when stomach contents get into the lungs, a serious complication. So those longer holding periods for weekly drugs give the stomach more time to empty properly before anesthesia.
Ah, okay. That makes sense. A really practical reason related to the anesthesia itself. And what about some of the other, maybe slightly less common classes? Can we touch on those briefly?
Sure, quickly. Thiazolidinediones, or TZDs, that's pioglitazone, rosiglitazone, generally held the day of surgery. The main risk there is fluid retention, which can be an issue, especially if you have heart problems. Then there are alpha-glucosidase inhibitors, like acarbose, also typically held the morning of surgery. Their main side effects are gastrointestinal gas, abdominal pain not ideal before or after an operation. And lastly, DPP-4 inhibitors, sitagliptin, saxagliptin, linagliptin, aleugliptin. Many guidelines say these can often be continued right up to the day of surgery, although, again, Cleveland Clinic suggests holding them on the day of surgery itself. These generally have a low risk of hypoglycemia and are pretty well tolerated, so managing them is usually less complex.
Okay, wow. That's a lot of detail, a lot of variation. So let's bring it back. What does all this intricate information really mean for you, our listener? We've gone through the why it's complex. We've looked at different guidelines, specific drugs. What it really drives home, I think, is just how complex these medical decisions are. The specific plan for your medications, it absolutely depends on your individual health, the kind of surgery you're having, and crucially, what your own care team's protocols are and how they assess your specific needs. Trying to manage this alone feels like, well, like you said, a high-stakes gamble.
It really does. And this raises that vital question again, how do you make sure you're prepared safely? The answer is clear communication. Proactive, clear talks with your entire team. Your surgical team, your diabetes care team, everyone involved. They're the ones who can take all this information, the guidelines, the nuances of your health record, the specifics of the surgery, and put it together into that personalized plan that ensures your safety and the best possible outcome. They really are your essential partners, so don't ever hesitate to ask questions. No question is too small.
Absolutely. So, just to recap our journey today, we started by understanding the challenges of managing these meds before surgery. We explored the different guidelines out there from various expert groups, and we dove into the specifics for key non insulin drugs like metformin, SGLT2s, GLP-1s, and others. Being well informed, like you hopefully are now after this deep dive, it really empowers you, doesn't it, to have better, more effective conversations with your doctors and nurses. It's about being an active player in your own healthcare.
Exactly. And if we connect this to the bigger picture one last time, it's not just about which meds to stop or continue. It's about empowering you to be that active participant across the board. So maybe a final thought to leave you with. Beyond just the medication adjustments, how can you as a patient actively participate in optimizing your overall pre-surgical health? Thinking about diet, activity, stress, working hand in hand with your care team for the absolute best result. And please remember, this deep dive provides general knowledge. It's for background understanding. For specific, individualized medical advice about your health, your medications before your specific surgery, always consult directly with your entire care team. Your primary care provider, your endocrinologist, your surgeon, and your anesthesiologist. They are your indispensable partners in ensuring your best, safest outcome.